So the most often questions that I get asked, what percentage of patients qualify? 93% gets you to step 1 because 93% of the patients are metabolically deficient. 99% get to step 2 or 3, and then step 4 is up to you. I would suspect that if you're looking at a practice and you've got 1,000 patients in it, and you can generate an extra $800,000 a year, and you get to keep 60% of it, I would suspect that you'd put as many patients in as possible to step 4. And
it's like 93% of the step 1 for the step 3, how much what percent?
93% of your general population will qualify, and 99% of your step 1 population qualifies for step 2. Because you basically, those data points, once you've checkboxed here, I'll back up so that you've got it here. So step 1 was this review of systems. If you checkbox anything positive here, you go on to a more detailed review of systems. If you checkbox anything over here, you go on to step 2, which gets the blood testing, and then immediately 4 weeks later, you go to step 3. I can tell you that our sensitivity and specificity is so high. For example, like I was telling you, hemoglobin A1C underestimate. So why use that test when you can use LPIR and insulin and get an LDLP? Because that's much more sensitive. When I do an omega-6 to 3 ratio, less than 10% of my patients, like less than 5% of my patients have normal ratios. Almost all of them have other markers. A lot of them have high homocysteine, which is a close marker for Alzheimer's. A lot of them have high ferritin. Almost all of them have high GGT or are hedging to the higher end. Homocysteine greater than 11 is a problem. A GGT greater than 20 is a problem. Insulin greater than 10 is a problem. And so these markers are much more sensitive and specific than the traditional ones that we use. And we already know that they're going to qualify, and that's why we get to this step. And once they've gotten through 1 and 2, you know that they're going to qualify for 3. Whether you take them forward and do additional counseling is up to you. This will generate about another $1,600 to $1,800 per year for your practice per patient, but that's up to you if you want to do that. You don't have to, because you can still close all of the loop with this. Because every time we do a Measura test, we're counseling the patient. We're explaining what we're doing and why, and we're giving the patient takeaway information, and we're making recommendations for them. That's what our folks are doing, because that's what they're trained to do. So they're documenting the transfer of that information for you. And it is a non-physician. It's an ancillary service, but it's a non-physician. You can certainly bring staff in to do additional stuff, but we'll document what we need to make sure that we've closed the loop here. If you choose to do the additional stuff, that's up to you guys. A lot of offices that are super busy, primary cares, never make it to step 4. They just they're okay with 1,000 patients looking at that 844, and they have 5,000 or 6,000 patients. A lot of the ortho practices will get to step 3, but not step 4, because they know that if they can just modify the patient's behavior slightly and they do a slight amount of coaching, then they don't need to get to this far. The key element is closing the loop, because that's what the value-based healthcare is making sure that you documented outcome. You're going to generate a much higher HEDIS score. If you're looking at HEDIS scores, you're looking at MIPS scores. The issues that I see is HMO and capitation. If you're dealing with a large capitation population, I wouldn't do it. If you're dealing with a large amount of HMO, I wouldn't do it there. We can try to pre-cert it, but it's probably not going to work. If you have an ACO that you're forming, this is a great tool before you form your ACO, so you can have a higher risk-adjusted score for your patients and have a higher HEDIS score. But in your accountable care organization, if you're at risk for capitation, I wouldn't do it. If you're outside of risk for capitation, you should do it. This does not impact your chronic care codes, RPM and RTM. These go monthly. Lifestyle coding is separate. It's 26 codes that are separate and distinct from RPM, RTM, and CCM. Base pricing, we set that based upon your intake of patients. First 30 to 100 patients, we know what dollar amount is. We target 40%. We always hedge that you're going to make more than 60% or we're going to make less than 40, but that's what we target, and that's how we set the pricing. We recommend repricing at 6 months. You can cancel anytime. If you don't get paid for a test, you don't pay us. There's no questions asked, because that was our screw up. And we'll learn from that, because that means that our technician, because we our technician gets paid per test that we actually collect on, they will quickly learn, and we will have learned not to test that insurance or to find out why we didn't get paid on that, because that's our responsibility. Deductibles and copays, those are your guys' responsibility. You're to collect the deductible and copay. If you waive that deductible and copay, then that means that you're going to have less global coming in. That means in the next 6 months, we'll be decreasing the amount that we ask you to pay. Because if you're waiving the vast majority of your deductibles and copays because of financial hardship, and you're genuinely waiving it, then that means that we need to reduce. If you're not waiving it and it turns out to be more significant, then that means that the global amount would probably go up a little bit. Timelines. Between the time that we sign up and the time that you collect your first dollar will be 12 weeks. It takes us 2 to 3 weeks to identify somebody to bring on board. It takes us a couple weeks to get them on board and trained into your systems. And then about 4 to 6 weeks later is when we first start testing. And you'll start to see payments about 2 to 4 weeks after that. So we estimate about 12 weeks. You have zero responsibility if there's zero payment. And that's why we don't want you to pay us till 30 days after you've been paid.